Excellent.
Good morning, everyone. I am Leanne Godino. Thank you very much for joining our presentation this morning. Today, we're fortunate enough to have a talk with Dr. Danie from Merwe. Just to give an introduction to him and a bit about his background. He qualified as a medical doctor from the University of Pretoria in 1991. He then worked in the Department of Family and Emergency Medicine unit at Kalafong Pretoria Academic Hospital and obtained his M.Med in Family Medicine in 2000. He also worked as supervising medical officer with Gauteng Emergency Medical Services and obtained a diploma in primary emergency care, which was the highest qualification in emergency medicine in South Africa at the time. Dr. van der Merwe then spent 5 years in Canada, working in various major emergency departments, gaining valuable experience. After returning to South Africa, Dr. van der Merwe spent the next 10 years in various emergency departments in Pretoria before successfully taking over the newly established Mediclinic Midstream Emergency Centre. After 5 years here, he teamed up with his colleagues, Dr. Bianca Vermeulen and Dr. Skalk Augustine, managing the emergency centre at Mediclinic Brits, as well as the accident and emergency unit at Raslo Private Hospital. Dr. van der Merwe is also qualified as an airline transport pilot, flying for an air ambulance service in his spare time. So today, he'll be giving us a presentation regarding bites and stings and the management thereof. Over to you.
Yeah, thank you very much. It's an honor to be able to do this presentation. I didn't realize it's going to be so big, so that's no pressure. I just want to say that, management of bites and stings, I'm by no means setting my out to be an expert, but I am in a privileged situation to be surrounded by experts. So I think it's very important to have the correct contacts so that when you're dealing with an emergency that you may not see every day, or that's very complex, you know who to call. So as that who wants to be a millionaire is phone a friend. It's quite important. Right, so we're going to start right at the beginning of our arthropods, and so just sort of a taxonomy. So the arthropods are, and we're going to start right at the bottom. You got the winglets called Aptera, and we're going to discuss some of those. Then you've got those that's got wings. There's the 2 wings, the Diphthera, flies, horseflies, mosquitoes, and then 4 wings. Your dissimilar pairs that your beetles and your partly hardened 4 wings is the true bugs and the bed bugs. And then we're going to move over to your similar pairs. So you've got the butterflies, your dragonflies, your bees, your wasps, and your ants. Right, so we're going to start really small, and we're going to look at lice. Now, these are by no means dangerous, life-threatening, but they can create a nuisance. So they feed off the debris on the scalp and on the skin, and they also bite you. They can leave these tiny little red marks. The lice is typically during the day, and they often confuse with bed bugs, which is typically during the night. And if you've had children in school, if you heard of children's school, they get the lice in their hair from other children, and then you need to treat it, but then the mothers have to spend hours trying to brush that eggs or the nits out from the hair, because the Nix shampoo and the Nix lotion doesn't kill the eggs. But it is direct contact, so if you're in contact with somebody who has lice, you can contract the lice. It is not just innocent. It can be vectors for Rickettsia, Borrelia, Bartonella. we don't want to discuss these conditions, but so in other words, it can be potentially dangerous. You can treat the lice infestation. And for us, a patient presenting of these bites, you can give antihistamines or corticosteroids. And obviously for rickettsia, your tetracyclines. The bed bugs, they are typically confused with the lice, and they are in the bedding, and they wake up in the morning with the red marks, typically over the body. And for those, you just treat symptomatically as well. Very important then to clean the linen, wash them in hot water, hang them outside in the sun to dry. If you don't do that, you're going to get the bites repeatedly. Moving a little bit bigger, you get your fleas. Now, the thing with fleas is they can jump about 30 centimeters, right? So they're almost like little tiny grasshoppers. They've got these massive hind legs. They can't fly, but they can jump. And when they bite you, it's severely itchy and causes red spots. Very similar to the lice, but a little bit more punctate. And typically it's on your legs, but it can be anywhere. And again, this can transmit rickettsia and African sleep sickness, trypanosomiasis. Again, it's treated symptomatically, and you can use a peaceful sleep or anything like that. It contains DEET that actually repels the fleas from your body. Right, moving on a little bit bigger, you get your ticks. So the ticks, now the thing about a tick compared to a flea is because it got this anti-inflammatory proteins in its saliva, it bites you and you're not aware of it. So it sits undetected for a long time, and you can see it's very small, and then it engorges itself with blood, and that's typically when you see them. And again, they can transmit rickettsia. And so the whole debate is how to remove them. So they basically say, well, just grab them, pull them off vertically as close as possible to the head, and just pull them away. If there's any teeth remaining, then you could just take them out of it instead of something. Right, very important. If you see an S-scar, which is that little bite with a necrotic lesion, high risk for tick-borne illnesses like, again, rickettsia. In the USA, they've got Lyme disease, and that typically only starts off about 10 days to 2 weeks. So any patient that presents with an unexplained fever that's been in the bush recently, you must ask about this. Right, so moving a little bit bigger, mites. So they're very similar to ticks, but they're actually smaller than 1 millimeter. It's very difficult to see them. And they actually can live on the skin asymptomatically. There's many types of mites. And of course, the most well-known one is scabies, where it actually burrows underneath the skin and causes severe itchiness. And for that, of course, you need the Tetmosol soap or scabial or Preventrin cream to actually repel them or actually remove them, kill them. Okay, then we move over to the housefly. Now, the housefly doesn't bite, but we're just going to start at one point. It's very interesting. The male is polygamous, but the female is monogamous, and some of the flies mate for a lifetime. And they actually feed on nectar as well as animal exudates, but they are a parasite, and they can transmit diphtheria, salmonella, the typical food poisoning and that kind of stuff, and even cholera. Then you got the fruit fly, and actually I heard an article this morning on a podcast where they've now analyzed the brain of a fruit fly. And they found a lot of similarities with the human brain, because they found it's much easier to analyze each and every cell of a fruit fly than it is to analyze every cell of a human brain. And they learn a lot about the human brain from actually analyzing the fruit fly. It's quite interesting. They do not bite humans, so it's just as a matter of interest. Then you get the tsetse fly. So this is the one that both the males and females feed on the blood. And of course, the most famous one, and you can see on the right there, the fly typically can be recognized by its wings. Although it's a diptera, its wings is folded over each other, which makes it very recognizable. And then you get the horseflies. Now, we don't have so many horseflies in South Africa. It's interesting that last name, Diptera tabanidae. That feeds on nectar and molecular. And just like mosquitoes, there's only the females that bite, right? And they do that in order to get proteins in the blood to lay eggs, exactly like a mosquito. And these are highly related to mosquitoes. Now, the difference between them and mosquitoes, there's some useless information. I'm not sure it's ever been bitten by a horsefly. It's actually painful. It feels like, I always when I was in Canada, it was teasing, it feels like it's taking a chunk of meat out of you. It actually does. So what it does, it's got very sharp antlers, or is that you call that the teeth, and they actually just cut you open, and then they've got a sponge-like tongue that just sucks up the blood. And that's why it's so painful. And they can, if a horse or an animal is infested or covered by a lot of these horseflies, they can actually lose up to 300 ml of blood per day. And it can actually lead to the death of animals. So it's not just innocent. And again, it can be a vector for parasites. Then you get your mosquitoes. Now, that's different from the horsefly. It's actually very similar in the sense that the females need to feed on the blood to lay eggs. But it's got a very fine stylet of tongue that it actually inserts into you, injects saliva, and in some mosquitoes, that saliva can cause itchiness. Interesting enough that the mosquito that causes malaria is not as itching as some of the other ones. So, the other thing is, if the mosquito bite itches, it's unlikely the malaria mosquito. And then, of course, in Canada, they have the big problem with Western Nile, the mosquitoes there. They've got a lot of mosquitoes, and of course, everybody knows Zika. All right. And then the ants. Now, South Africa, we don't have a big problem with stinging ants, but worldwide, you get this fire ants that is in America, now in Australia. So a big problem. We've got, and interestingly, a bullet ant in Central America is the most painful bite on the Schmidt sting scale. Is the most severest form. It's almost like the Schofield units for capsicum and chilies. So it's interesting that an ant is the bite's more painful than a wasp or a hornet, or rather its sting. So Africa, we've got the Cape fire ant. It's only in the Western Cape. Because it causes a painful sting and a bit of itchiness. And then we get to the bees. Right, and there are many types of bees. We've got the African bee and a Cape honeybee. And so, again, it's only the females who have the stingers. And I still remember as a small boy, and I was stung by a bee. My dad consoled me by saying, "Don't worry, the bee is going to die anyway." And actually, they don't always die when they sting. If they sting other insects in terms of self-defense, they can actually sting repeatedly. And they've got more poison in the sting than a wasp, a bigger volume. But when they bite or sting a mammal, the stylus has got this two barbed sliders, and literally the stylet goes in, and the barbed sliders is almost like an electrical saw. It actually moves up and down, so it hooks in the skin, and of course, when you pull away, the skin, part of its abdomen gets ripped out, and therefore it dies. But that action of drilling into your skin continues because of this alternating movement of the barbs. So we were always taught that you need to take something sharp and you just scrape it off. But what they now find is when you've been stung by a bee, to use any means by possible, even if you pinch it, take it out as quickly as possible. Otherwise, the injection of venom continues. They found that you get less venom by pinching and pulling it out, by leaving it longer than looking for something to scrape it off. Right, and so typically 50 micrograms of poison is injected. Put ice on, local anesthetics, some menthol, topical antihistamine cream. Only 2% of us allergic. And of course, they have to use EpiPen. Right, and then So yeah, that it's got that apitoxin, and it's got things histamine. So all the stuff that causes a typical reaction. Melatonin, that's antigenic. And interesting, when it stings you, it releases the pheromones. And if there's other bees in the area, it makes them livid. And then that's why you get stung by a bee. All the other bees, especially if you're near the nest, is going to attack you. And that's the problem with the bees. All right. Then you've got the wasps. So interesting on that pain scale, the Schmidt pain scale, the bees are about 2. And then you get the paper wasp, and they call it paper wasp because they bite off pieces of wood and they build a nest that looks like it's made from paper. And they typically they fly with their legs hanging down. Again, only the females sting, and this is slightly worse, a grade 3 on the Smith sting index. And of course, they can sting you repeatedly, even though they inject a small amount. So obviously, this is a controlled injection, small amount of venom, but they can sting you repeatedly. Then you've got the hornets. It's a little bit bigger. In South Africa, we get the German hornet. It comes from Europe. It's not indigenous to South Africa. These are almost actually a pest because they build their nests underground, so you can't see them. You have a picnic, and they're actually looking for food, and they will become a nuisance. A little bit more aggressive. They fly very much like a fly or a bee with their legs tucked in, and they look very much like a bee, but pack a little bit more of a punch. Right. So I always thought that you can't get allergic to wasps and hornets, but you actually can. And the reason they say is that the venom is slightly different. But because people are much less likely to be stung by a wasp or a hornet, the incidence of allergies are slightly less than that of bees. But it's almost like a peanut and a tree nut allergy. They seem similar, but they are completely different. So if you're allergic to bee sting, you're not going to be allergic to hornets or wasps, and vice versa. Right. So we're going a little bit bigger now, and a little bit more dangerous. Right. So we get your black and your brown button spider in South Africa. It's actually quite a beautiful spider, if it wasn't so dangerous. And again, that typical marking on the ventral of its body. And I remember the one time in my apartment, I saw these beautiful webs every morning, but I couldn't see the spiders, and they actually hide. And I used a spray can and Doom, and I sprayed all along the bottom of the curtains. The next day, a whole bunch of brown button spiders lying on the floor because they actually hide. And obviously, they spin this web to catch smaller insects, and then they poison them to paralyze them, eat them. Right. So the neurotoxin here. So all these spiders are neurotoxic. Lactotoxin, and it binds to the presynaptic neurotransmitters, right? And it releases the acetylcholine and noradrenaline from these neurons. And you get like an autonomic overstimulation. Now, contrary to snake bites, when a neurotoxic spider bites you, it's immediately painful and it feels like a pinprick. And then it gets progressively worse over the next hour. Now, this can last for a week and sometimes even longer. And you get this pain and the severe envenomation. You get severe muscle rigidity. With your chest, they struggle to breathe. Abdomen can mimic an acute abdomen, leading to cramps, vomiting. Because of sympathetic stimulation, sweating, flushing, edematous, red edematous face, raised blood pressure, and pulse. And what it does is an overstimulation that eventually leads to fatigue, and in extremes of age can eventually lead to death. The black widow spider in America is fortunately more dangerous than ours. So we don't see a lot of fatalities, very seldom fatalities of that. Right, there is an antivenom available, although in South Africa it's easier said than done. So basically, you give the patient a tetanus shot, you give them paracetamol, you can inject calcium gluconate. The problem is, so you get 10 mils of 10% calcium gluconate. The problem is it only lasts about half an hour, and then you can only use so much calcium gluconate. And then you can use you can actually infiltrate the wound a little bit with a local anesthetic, they say, and then that will reduce the pain. Like with snake bites, you can inject a little bit of adrenaline before the time to counteract potential anaphylaxis, but with the antivenom, with spider bites, you shouldn't, because you've got this sympathetic overstimulation already, and it can actually make it worse. If you do get the antivenom, and I've never seen somebody give it, and I've spoken to some experts, and they say it is available, but not readily available. So it's from the South Africa Institute of Medical Research, small amount, 5 to 10 mils, and within 30 to 60 minutes, a dramatic improvement. And you should still observe them for at least 6 to 12 hours. If you don't give it, you have the risk of these symptoms persisting for a week. It can be very problematic. Right, and so this is with all these toxic bites. So now, neurotoxic. It is sometimes difficult in the beginning to determine whether it's a cytotoxic or neurotoxic. It's very similar to scorpion stings. It can be confused with snake bites if you haven't seen the spider. Because of the chest pain, it can look like a heart attack. It can look like a cholecystitis, appendicitis. Because of the salivation that you sometimes get, it can be like organophosphate poisoning, even alcohol withdrawal, tetanus, meningitis, poliomyelitis. So, in other words, if you haven't seen the spider, the patient presents with these symptoms, it can be actually very difficult to determine if you don't see or don't have an accurate history. Get the violent spiders. So, as if you zoom in, you can see on his back there, behind his head, you can see that typical violent pattern, and it has 6 eyes instead of 8. So the thing is, this has got a democratic agent. So they call it either necrotic cutaneous. So this is cytotoxic, right? They call it loxoscelism. So it causes significant, although again, it depends on the amount of toxin that's been injected, and also the body part. For instance, if it's on the finger, it's obviously much more severe than it's when it's on the leg. And you get this typical necrotic lesion, very much like a tick, where you get that central escarp, but of course much bigger. And it takes weeks to heal. And then you can get some viscerocutaneous loxoscelism, nausea, vomiting, a fever, because of a bit of a neurotoxic component as well. The bites is usually painless. So again, as opposed to snakes, the cytotoxic bites are painless. And then typically after an hour, you start feeling some irritation. And people are quite often surprised, and after a couple of days, you see a pimple. And of course, it just progresses, and there's not much you can do. I mean, they don't recommend you give antibiotics prophylactically, so you basically just treat it symptomatically with local topical debridement, applying some, you can put some antihistamine ointments in the beginning, some Bactroban, and let it heal its natural course over the next few weeks. Right. So there's a lot of treatments that they propose. Of course, we know about hyperbaric oxygen that helps to increase oxygenation to that potentially viable tissue surrounding. Dapsone has been described. antibiotics, dextran. None of these have actually proven to be superior. And they don't recommend routine surgical excision, rather just conservative management and until it's well established to see where it goes. The sac spider is very much like the violent spider. Usually the effects is not as severe as the violent spider, but the sac spider is much more frequent because of its contact with humans. And typically, so it's called a sac spider because it spins this silk cone that it hides in during the day. And the females actually enclose them in that when they lay their eggs until the eggs hatch. They hunt during the night. And that's typically what happens. They go into your clothes because they're hunting. You put on your socks, and I've been bitten by a sac spider in Africa on my ankle, and typical. It takes, you see that pimple, it starts itching, but then it's too late, the spider's gone, and then you form that little ulcer. Typically smaller than a violent spider, but I mean, there's just nothing you can do. It just falls into an ulcer, it takes weeks to heal, and you just treat it symptomatically with, can put some Bactroban on. Then these are, so the six-eyed sand spider. Again, we don't often see them. You get your baboon spiders. A lot of people actually keep them as pets, the tarantulas. And they've got a very mild neurotoxin, but they can cause limb swelling and discomfort. But it's not deadly. And the same with the rain spiders, beautiful spiders. Similar to the huntsman spiders, is very, very well known. And again, also a mild toxin, but not deadly. Right. We're going over to scorpions. It gets prettier and prettier. Again, it's a bit of a revision. So you get about 4 major types of scorpions. Scorpionidae, so 42% of bites and Buffidae, 34%. Fortunately, the Scorpionidae and those sort of ones with the bigger pinches and the smaller antlers or stingers, and that's less dangerous. The one that we see most is the Europlexus, the lesser pigtail scorpion, and that's the one second from the bottom. And then the pseudo Alicius, the pygmy-tail. And again, people often come with them, and actually the picture doesn't do justice, but it's literally just only a couple of centimeters big. But it's a most beautiful scorpion. They bring it in a little bottle, and it's been stung by it. And it's, of course, it burns, and people are concerned they're going to die. Again, we must say that the scorpion stings doesn't often cause death. They're big, dangerous in small children. So, of course, that Buffidae, and you can see, man, it just looks dangerous. It's got the typical rule of thumb. It's got the small pinches and a big, nasty-looking tail. So you got the Parabuphus transvalicus that's on top. That is what we have here in Gauteng, and the Granulatus, which is more in the Northern Cape. And if I get stung by that, I'm probably going to die from a heart attack before I die from the toxin. And again, it's a neurotoxin. And people know they've been stung because it's painful, right? So similar to the black widow, it can last for weeks, and it starts off by causing this paresthesia, and then typically here hyperesthesia. So when you get scorpionism, they call that syndrome, your body is so tender. It's like even the clothes, you want to rip off your clothes because it's so sensitive. Nothing can touch you. And it's intolerable for people. And because of this generalized release of noradrenaline, again, acetylcholine, very similar to the scorpions, hypertension, tachycardia, fever. It can also have a muscarinic effect. So it can lead to the dysphagia, visual disturbances. In children, And it's much more dangerous. And what happens is the child becomes literally inconsolable. It's not just related to the pain. They become restless because of that neurological overstimulation, fasciculation, jerking movements. And in children especially, it can lead to respiratory failure and death. The good news is there is an anti-serum. So what they recommend is that obviously a person is bitten by a suspected parabuphus. Your symptoms should develop, your neurological symptoms should develop within an hour and establish within 2 hours. And you should consider getting the anti-serum as quickly as possible for this because it has a dramatic effect. So you need to support them, transport to the facility that can manage them. They say you should avoid opioids and benzodiazepines, and it sounds contradictory because they've got this sensory, this overstimulation, and you want to give them something to release that spasm, similar with the battle spider. But they say you just have to be careful with benzos. Of course, you go in a hiking unit, you can give them careful titration of benzos just to relieve that overstimulation. But be careful not to cause respiratory failure. Again, you can give local infiltration because the wounds are extremely painful with local anesthetic. You can give calcium gluconate, but again, it's an acute treatment for 30 minutes because you can't keep on giving the calcium gluconate. Again, you can give 5 to 10 mils of the anti-serum. You can repeat it in 6 hours. And they say that within an hour, you've got almost complete resolution of the symptoms. You have to give it early. Right. Now the main star. Good morning. So, again, we are very fortunate, and we might jinx ourselves, but we don't see a lot of snake bites in this area. But in Brits, this is going into season now, so we should see more snakes. You get the 3 main types: neurotoxic, cytotoxic, and hemotoxic. Although this is always sometimes, unfortunately, the snakes don't read the textbook and they don't go to medical school, so there's a bit of an overlap in the symptoms. So what they've done is they described it into 5 main clinical categories because quite often you don't even see the snake. So you get the one where you've got extreme local pain and progressive swelling. But your blood is clotting. And that's typically the cytotoxic. Then you get progressive paralysis with minimal swelling, that's neurotoxic. Then you get your incoagulable blood with minimal swelling, that's the hemotoxic. And then you've got some cytotoxic neurotoxicity, and then just your mild cytotoxic symptoms. Right. So here we go, and we see our old friend, the puff adder. And then second top, the spitting cobra, and specifically the spitting cobra. And the way I remember it is, if they spit into your eyes, it causes damage to your eyes because it's cytotoxic, right? The wrinkles, which is not a true, looks like a cobra, but it's not a true cobra because it's got fixed teeth apparently. So it's got digestive enzymes, so it destroys tissue. And within 30 minutes, you'll see the effect. And this is very important. And we'll go to the criteria as when to give antivenom. And apart from the swelling, they can write a whole page on the clinical presentation. But so typically it's progressive swelling and edema. You get discoloration of the skin and blistering. And again, it depends on the size of the person that's been bitten. And also, if it's on a finger, it's obviously much more severe than on for instance, your leg. But typically, they'll bite you on your hands or they bite you on your lower legs. What they say is, monitor these. Don't go do early debridement because you want to see where the delineation is because of the necrotic tissue. So they say you can wait a few days because if you debride too early, you have to go back and back and back to debride. So just rather wait until you've got a clear delineation and you go once out. So say sometimes you have to wait up to 10 days before debriding. Of course, in the blood test, we'll do that, the myoglobin and the CK. We'll check for the platelets. And sometimes with severe bites, especially the Gabon adder, you can get rhabdomyolysis because of this massive muscle breakdown that can lead to renal failure. So we have to watch out for that. Now, the one with the progressive paralysis, those are the non-spitting cobras like the Cape Cobra that we have. And of course, for me, the most deadly looking snake of the black mouth is the mambas. Fortunately, we don't see the green mamba often. The black mamba, I mean, that's a popo, so we could potentially encounter it. Again, very similar to the scorpion bites. So in this case, it actually is like a presynaptic. It displaces, it's got a few ways to work, but it displaces acetylcholine, leads to a flaccid paralysis. And it's actually, compared to Guillain-Barré, this is a descending paralysis. It starts with your facial muscle, toes of the eye, drooping of the face, difficulty speaking, and eventually swallowing, and then move down. Eventually, you can get respiratory failure, massive fasciculation, and that cause cardiac arrhythmias. So there is a bit of a cytotoxic component to it as well. And you can die with, I mean, a massive invasion, small person within an hour, but typically in about 8 hours. So it's very important that these. So very important that these, especially, well, all the same, just to get them to a facility with a respiratory failure, if you are able at least to support the ventilation. So when you transfer them to a bigger facility, as monitored the ventilation. I once saw this documentary where a person was bitten by a neurotoxic snake, but they were in a remote site. But he was an expert, and he told his team to please ventilate him if he can't breathe. And they did, mouth-to-mouth breathing. And then they came with a first aid kit, and there was a bag valve mask in it. And they started ventilating him. And then he died because there was a little valve in the VVM missing, and the people weren't trained. And they were ventilating him, but they weren't moving air. And of course, he died. So we see this often that the VVMs doesn't have the valves in place. But you can save a person's life by ventilating. Then you've got the boomslang. Now, not very common as typically snake handlers because the teeth is in the back. So they have to get a really good grip on you before they can actually inject the venom. So the most common is snake handlers. You also get the vine and the twig snake. And that activates clotting factors 2 and 10. So what it does, a massive stimulation. So you get your formation of the fibrin, but it's in a very immature way. So it depletes all your platelets, typically within 24 hours, and then you just start bleeding all over. Nausea, vomiting, abdominal pain. So literally you start bleeding from everywhere, almost like a hemorrhagic fever. And this soon leads to multi-organ failure. So, I mean, and it's usually fatal. So, and then you got your swelling with neurotoxicity, your berg adder. So this is an adder, so it's cytotoxic, but it actually has neurotoxicity as well. And then you got your night adder. So not much systemic symptoms, but it can cause painful bite and swelling. Again, you can see if you're not experienced, you won't be able to distinguish. And I don't advise you to try and remember the patterns and for the once in a year that you might see these snakes and then say, oh, don't worry, this is only a night adder. It's not that dangerous. In the meantime, it's a puff adder. All right. So this is very important. So your supportive care, as Jason Seal told me, he said, you have to reassure this patient because they think they're going to die, and that causes a symptomatic stimulation, overstimulation. And eventually you don't know what is neurological signs and what is anxiety. So you have to reassure them. Then also keeping the heart rate down, keeping them calm, easier said than done, reduces the spread of the poison. or the venom. So therefore, immobilize the person as a unit. So don't let him walk. Don't so carry him if you have to. Keep him in a resting position. Don't apply tourniquets. Don't cut the wound open and suck the blood out. Or you get all sorts of fancy things to actually extract the poison or the venom, as we were taught many years ago. If it's a neurotoxic bite and you're very far away from the hospital, you can apply a constrictive bandage, like a crepe bandage, over the limb to reduce the circulation and reduce the spread. Remember that the poison, the venom spreads in the lymphatic system, and therefore putting a tourniquet on is not necessarily going to help, but it can cause more damage, right? And then monitor this patient. They obviously don't try and catch the snake because you get bitten twice. Nowadays, we all have cell phones, so if we can take a picture of the snake, it can help. Again, they say avoid opioids if it's neurotoxic, again, because of the risk of respiratory failure. If it's hemotoxic, avoid obviously Disprin and NSAIDs. Right. So there is an antivenom available, and all hospitals in high-risk areas should stock it. It's 10 ml vials. Now, you don't use it for your minor bites like the Berghardt and night eider, and then there's a separate antivenom for the worm slung, and the one is not effective on the other. Now, there is, I spoke to Jason Seals, so there is an alternative, a panosnake venom that's made in South Africa, and is becoming a very effective alternative for the polyvalent venom, the antivenom that we have, because it's freeze-dried, it can be stored for up to 4 years, and it's becoming much more readily available. And there is some telephone numbers they're going to provide, so you can actually call them and they can actually provide this for you because they have a stockpile of this. Right. For the neurotoxicity, rather, indications for administering antivenom. Any signs of neurotoxicity as soon as possible, right? Any abnormalities in your blood clotting profile, start giving it. If you see any discoloration of the skin leading to possible necrosis, give it. Rapid, so what I say is that you monitor. So, and we had a case in Brits, but so he was bitten on the hand. So now you watch it. If that swelling is moving more than 5 centimeters an hour, you give it. You don't have to wait until the whole limb is involved. But if you see that the whole hand or foot is swelling within an hour, or to the knee within 6 hours, or the whole limb within 12 hours, you must give it. Right? There are any signs of the compartment syndrome, threatened airways, cardiovascular compromise, then you give it. If you see that it's a worm slung, you give it. All right. So what we do, and contrary to scorpions and black widow spiders, you give a shot of adrenaline. They still say 0.25. It actually says subcutaneously, but we give it either subcutaneously or IM nowadays. And you wait about 10 minutes for the effect. What I say, there's no benefit in giving them a loading dose of antihistamines or steroids. Steroids takes too long. Antihistamines not been proven to make a difference. Give them a small dose of adrenaline, wait 10 minutes, and then you give your dose. So neurotoxic, anything from 80 to 120, cytotoxic. So typically a safe dose that they say to start with is 10 volts, right? Start with 10 volts. Do it properly. And because you want to counteract venom with antivenom. Hemotoxic is a smaller amount. You can reduce the side effects by dissolving it in 200 ml of saline and slowly administering it and looking for any signs of anaphylaxis. And when it works, you have a dramatic effect. Within 30 minutes, you can see, especially with neurotoxicity, you see a reversal of the symptoms. The swelling and the cytotoxic bite might take a few days to improve. So you're going to see a dramatic, but it's not going to progress, right? And then, of course, these patients all need to be admitted to a high care unit and be observed. And you can repeat it in an hour. Right, just some references. And then, of course, the person that's very helpful, especially in Brits, is Jason Seal with the Hardware Snake and Animal Park, and I had a long discussion with him regarding this. And he's available 24/7, but there's a few other guys as well. And on that snake bite flipper card, there's all the contact details of all the people involved, and these people are absolutely amazing because they deal with this every day, and they can tell exactly who's been bitten by a snake where. And every time I get a patient with a snake bite, I call them and they guide me through the decision-making process to decide, what should be done for this patient. Okay, that's it.
Wow, thank you very much. That was very, very interesting. I think you'll have to ask if there are any questions from anybody. I think maybe anybody online first.
Still there.
Yes, 46 people still there.
Oh,
36.
46.
46.
Yes.
Went up to 50.
Maybe I can ask you a question.
yeah.
I just wanted to know, did you come across, if you have a patient with a scorpion sting, can you have an anaphylaxis as well? Or if you see respiratory distress, is it more part of the sort of the venom?
I've never come across a scorpion sting that
Okay.
caused an anaphylaxis. I'm not sure if anybody else had.
Yeah.
And I think because it's a neurotoxin, I think neurotoxins are probably less likely for some reason to cause an anaphylaxis rather than a cytotoxic. But I also think is that because we very infrequently get bitten by scorpions and snakes, so the risk of a second exposure and potential anaphylaxis is probably very slim. The same with hornets or wasps and bees. You get stung more frequently by bees, and then your second exposure you can develop an anaphylaxis. Whereas, I'm not sure if there's anyone out there that's got a different experience, but I've never seen a person developing anaphylaxis from from any scorpion, spider, or snake.
I think in terms of spider, I remember when I was in Secunda, I have a gentleman that was breeding the black widow spiders, and he had a bite that really he was quite sick, so we have to get the source antivenom from Cape Town. So I think for black widow spiders, definitely there's antivenom, but I think you need to obviously to get the right center to access it, because most of those without antivenom, most of these patients really don't do very well. Yeah, but I think it's really this is quite very nice, exciting talks. Online, anyone please? Questions in chat. No?
Don't see anything on the chat.
I must
Oh, I guess so.
the meeting chat. What is that? I must say that
Question.
I must say Mashida Keiji actually I must also extend thanks to her, because somehow when I was working on this presentation, she started contacting me on WhatsApp, and And she says, "Oh, I see that you're presenting a lecture on bites and stings." I said, "Yes." And she met me at some wars at University of Victoria the previous year. And she actually forwarded me quite a few names and numbers of people I could contact. So Ashura, thank you very much for that. This shows that everybody that's involved with snake bites are so passionate about it that all of them will tell you that you can contact them at any time, and they would be glad to help you and give you that. So you actually basically, the other person that she gave me a few contact details. It was obviously Professor Dries Engelbrecht. Then there was obviously Jason Seal. Then there's Mike Perry that I've dealt with quite often as well. And that's also, and then Jonathan Leeming. I spoke to him actually briefly on the spiders. He's actually quite an expert on spiders. And then there's Prof. Tim Hardcastle. And these are all people that's actively involved. And on this flipper chart, many of their telephone numbers are there. So if you can get this flipper chart, it's actually quite handy and it explains the whole process. There's even got a little chart that you can monitor your progress. And then the other book that's quite valuable is the book from Prof. Dries Engelbrecht, Primary Emergency Care at Pretoria Academic Hospital. It actually got a whole section on bites and stings. Because a lot in literature that you would find is more based on European and American data and not so much South African data.
Yeah, so what we can do is that I think the podcast should be available tomorrow or the day after tomorrow, and we'll try to create a link for the books here, the books that everybody should be able to access, and then also the snake flip card. You know, it's very important because I think especially those working on the emergency department, so they can have the knowledge and the power, obviously, to save your patient lives. We'll make those available to make sure that there's a link and the actual way you will be able to buy the books if it's they're in the store, or at least, you know, and also maybe give you a contact of Danie, who has become an expert in the bite and stings, so that at least, you know, because I think you always need to have that colleague. You know, sometimes you get, experience these patients and you don't know what to do, then you can't just call a colleague and then he can help you out. It's always called a friend. So that's really the aim of presentations. And obviously, I think if possible, we'd like to have all your emails so we can extend for you further invitations. We're going to be having the meetings on every Wednesday and Tuesday, a lot of different topics. It's going to be exciting and they're available on podcast too. So we're very excited. Thank you guys for joining us, obviously. It's been great. Yeah.
One question there from Patrick Wallet.
Hi, morning, Doc. Hi, everybody. Just a question, and I think I may or may not have my facts straight here. Do we get a brown recluse spider in South Africa, or is it just commonly sort of mistaken for the sack spider?
I've never personally come across a brown recluse spider. If I can just go through my details. So in terms of the spider bites.
Can I interject
Yes.
2 seconds? Hi, Pat, it's Bianca.
Morning, how are you?
Fine, thanks, and you?
Always good, thanks.
Pat, so we don't get some of the snakes or some of the spiders in South Africa naturally. So by the time somebody says they've been bitten by that kind of spider, it's usually somebody who has imported them and they've got this little collection at home. So I've never seen a natural, somebody who brought in a spider that just bit him in the veld with a brown recluse. I think they get the names confused with the other spiders. But we do have people, you can ask Mark Stanton about it. They have people who collect spiders at their house and then they will tell you what spider bit them. And that's the only time you get these odd spider bites where you can actually tell the spider's name, because usually they bring you a squashed little brown thing. You can't identify the spider.
Okay, fantastic. Thanks very much. Appreciate it.
Also a question from Jenny.
From Jenny Blichnout, there was a hand up earlier. I think she's.
Jenny, are you still
Good
there?
morning. I'm here. Good morning. Sorry, this might be a very ignorant question. So I was listening to Johan Marais talk last night as well, and he was referring to a black button and a brown button spider. So the black button, is that the black widow, or is that just a different type of black
Yes,
spider?
so the black button spider is often referred to as the black widow. The black widow is typically the American one, which is quite dangerous.
Because by the sounds of it, sorry, the signs and symptoms of the black and the brown button sounds pretty much similar. The black is a little bit more aggressive, but the brown is the one that you spoke about a bit earlier.
Now, the black one is, even in South Africa, the black button spider is more dangerous than the brown one. It's not as common as the brown button spider, but it's more dangerous.
Thank you so much.
Thank you. I don't see any more hands up, so I think we can, if there's nothing else, thank you again for attending and listening to the presentation. We hope to have you again next week.
We'll send out flyers, I think, next week for the topics on Wednesday and Thursday. I think should be available by Friday. And as I mentioned again, the podcast should be available. If you miss the presentation or your colleagues miss the presentation, you can get Keisha Danie presentations on the YouTube, which will share the link and should be available. And you can listen during your driving or at home on your leisure time. And also those who are interested in CPD points, I think we will probably next week will try to create a system so that they can be able to get their points for the